like to invite you for that session. It is a topic, endometriosis, which is commonly thought to be only in premenopausal women, and we'll learn more about it later on. So that may be the reason why not all of them have thought they should come to this session, but maybe we should have spread the word. And as you will see, the three topics are linked, and I will co-chair it together with Dr. Anderson to bring you a bit closer some of the new aspects. And the title, which is the first speaker, which is me. My name is Ludwig Kiesel. I'm from Germany, as you can see from that slide. And the organizers asked me to give the perspectives as an initial talk about the diagnosis of endometriosis in the 21st century. So we are quite in the beginning of that century. So we still have a lot of time to figure out how we can do better than we're doing now. And as you will see, my idea was to look into the future by looking at more dynamic people like in the film industry. And the 21st century productions for endometriosis will be highlighted in my slides. But looking back to history, endometriosis has been already alluded to in all textbooks in the 13th century. It's one of them. And it hasn't been called endometriosis, but it was a kind of uterine suffocation, what it was meant to be. And it was described as symptoms which are similar to what we describe today as endometriosis-like disease. So do we have solutions for diagnosing this disease properly? Now, my talk has 4 topics. One is to tell you what is endometriosis, if I can. And then we'll see what we are doing today as a diagnosis for endometriosis. And finally, we have to look at the challenges, how we can improve that. And finally, also to see what options there may be. Now, what is endometriosis? As you all know, this is basically a kind of tissue which is ectopic with regard to the endometrium. So it's ectopic endometrioid glands as well as stroma. And there is, it's not clear how many percent of women do have endometriosis, but it's up to 6 to 10%. And especially if you look in certain groups like infertile patients or patients with unclear pain, then this goes up to 50%. Now, due to this, a lot of problems these women have, and their absence from work, etc., this disease has a high socioeconomic relevance. And to me, apart from that, the major problem is the length of time to diagnose the disease. So that's my topic. How can we improve diagnosis? And there may be several ways to do it. Now, endometriosis and the pathogenesis itself is an enigma. And we all know it's actually a chronic disease. And it causes a kind of inflammatory reaction, and it will lead in the pelvis or wherever it is to anatomical and functional changes. So there may be different ways to look at it. Now, the current knowledge of the pathogenesis and the spontaneous evolution, as well as pathophysiology of the related infertility and pelvic pain, remains quite unclear. So we don't know how all the different types of disease will relate to it. And there is no real definite cure. And we all try to cure patients, but there is no real definite cure for it. Now, if most of us think it's just intensive cramps, what are the signs and symptoms? But of course, there is loads of other different more or less pathognomic symptoms which may relate to the disease. And this is one major issue what I think needs to be improved, that whenever some of these symptoms occur, that we, not as a specialist necessarily, but all doctors who are consulted by patients with these symptoms should refer these patients with regard to the diagnosis of that disease. And that's the problem, that it takes too long time, and there are many studies on that it takes worldwide almost 10 years from these symptoms until the definite diagnosis is made. Now, another problem is that severe type of endometriosis, which is called deep endometriosis, is usually palpable if you do a proper rectovaginal exam. And although this is bothersome to the patients, one should do that if there is some kind of unclear pain. So I think one should insist that any workup of endometriosis should include this examination. And I think if those of you who perform that kind of exams will know that you can often easily determine deep endometriosis if it's lower in the pelvis. So that is actually a very important feature. Now, how we do it today? How is the algorithm? So generally, if you talk about the symptoms, which are shown here, I'll try to see that. And it's, in addition to that, you do this exam, what we've been talking now about, in addition also some imaging, which I will not go too much into. That will be one of the following talks. And generally, we don't perform much biochemical parameters, and we decide if there are normal findings or any pathological findings. And we can go for a treatment, medication, which is usually a pill or other endocrine or non-endocrine treatment. And if there is no success, you can go for laparoscopy. Or if there are already pathological findings, you can go straight away to laparoscopy. So that's basically how we, in my country, think about the way to deal with that kind of algorithm. Now, what are the challenges? Now, in general, you have to find out if there are some relations already in the family, and it's quite surprising to hear sometimes if you operate on a patient that the mother and even the grandmother says that that they say they had also disease which has not been found beforehand. The problem is that if you do laparoscopy, the findings are often not well correlating with the symptoms. So sometimes you have severe pain and you don't find much, and then the opposite can occur as well. And the same applies to the different symptoms, so like dyschezia and other changes of the ovary. And there is not a really good correlation, but there is some indication that these kind of symptoms and anatomical changes can correlate. Very bad prediction is for the lower stages 1 and 2. Now, the gold standard is everywhere said it's laparoscopy. So if you can't really palpate the disease and you have no real diagnostic test, which is non-invasive, then you do laparoscopy, which is both for diagnosis and also treatment. And what you do, obviously, as we know, is you inspect the abdominal cavity in general, and then the question is, do we have to make further diagnosis of the tissue? So in some countries, histological confirmation is required. Like in our country, we say in our guidelines we should do it. But it is quite debatable because it's unlike in cancer. Pathologists usually don't make many confirmatory slides to investigate it. So there may be some difference. I will show you the idea behind it. So let's have a look. So if you do laparoscopy and you see these 6 cases I've shown you here, now, and you look at the cases and you have to determine just by microscopic, just by looking at it, and then how much of those have been diagnosed microscopically. So as I can show you here, I didn't get all right myself, so don't be too annoyed if you don't know the proper answer. So that's on histology. But there is kind of a disagreement between surgeons and pathologists. So sometimes you say, I'm totally sure this is endometriosis, and you get back the histology, and then even patients read it and say, well, you didn't find it then in the end. So I think this tries to illustrate to you that it's not always as clear, and maybe the input by the pathologist is not regarded as so important because it may not be life-threatening disease. So how did actually the diagnosis of endometriosis evolve? What kind of steps have we made? Now, I just told you that actually you're not doing any real diagnostics until you do laparoscopy. So you could summarize that evolution of endometriosis diagnosis is a bit like evolution of rocks. So there's a time frame of 4.5 billion years, and not much happened. So that will have to change in the future. So how do we improve it? I told you symptoms and signs have to be looked upon, and it should be taken seriously and not taken for granted that this is normal and no treatment necessary. But further steps are required. We need better imaging. We have some imaging. We have to know how to do it. And Dr. Singh will give some examples in his next talk. And I will concentrate more on the two other topics. I mean, can we actually do some kind of non-invasive tests where we can figure out some details of the disease? So looking more into the molecular setting of that disease. Now, imaging will be covered, and as you will see, there are different types of diseases we have to look into, and that applies also to the biomarkers, which I'm talking to you about now. So imaging will be covered later. It is actually sometimes easy, as you know, from like endometrioma, more easily detectable, whereas others require probably more knowledge and more expertise, or they are not detectable by imaging. So a lot of effort have been put into the genetic profiling of endometriosis and to understand what kind of disease is endometriosis. And there have been different types of studies, as highlighted here. Twin studies, genealogical database have looked at, family-based linkage studies, and lately enormous amount of effort into GWAS studies to understand what type of genetic loci may be important. And just to summarize for you all that data is the bottom line of all that, for me at least, is that stage 3 and 4 endometriosis, obviously the more severe cases, are more genetically driven than stage 1 and 2. And there are about 12 genome-wide significant loci identified, which may relate to pathogenesis of endometriosis. So there has been a lot of international studies for this GWAS, and these 12 loci have been identified. So I think in future we will need these diagnostic methods, and most simple ways would be have blood biomarkers or have some kind of tissue biomarkers, or let's say urine biomarkers or proteinomes. The problem will be obviously that you can detect if the disease is there, but you can't tell exactly where, so you can't actually locate it by these tests normally. So if you look in the literature, so I don't want to list the whole load of different biomarkers examined, and I put in the 3 different groups as I've shown you before, and the most biomarkers which are supposedly have a potential for endometriosis are within looking at blood samples. And here 122 biomarkers, potential biomarkers, have been studied in 144 publications, and 7 markers for urine and 95 for tissue. Now we are working on some biomarkers, and one of the important ones, and we think it's the most important one probably, is something called microRNA. And those of you who know that will realize that in order to have something which is very specific, you need to have a stable molecule. And microRNAs are non-coding RNAs. So they are not coding proteins, but they are regulating RNA themselves. So there's a very complex method how in every cell, microRNAs are produced, and they are through cleavage procedures that several ways how they can interfere with the action and stability of RNA. And one microRNA can affect many different aspects, and several aspects are actually regulated by different microRNAs. So there's a kind of a big network, and many diseases are at present investigated for that. So we have been looking into that, and I've shown you where it initially has been discovered, and that was in a worm. Now let's see what can you use this microRNA for. Now if you look at different types of endometriosis, and that is ovarian, peritoneal, or rectovaginal, the deep endometriosis, you can see that there are numerous microRNAs which you can detect in these tissues, and they're expressed in a quite different way. So there are different microRNAs, and microRNAs can be expressed in different types of endometriosis in a different fashion. So you may end up actually not only diagnosing the disease, but you can actually tell what is maybe more likely to be relevant as a disease. And also, if you, not just in tissue, as I've shown you here, you look in the plasma, you can look at different microRNAs which are changed. So there's a fold change of microRNA. So let's say this one is 100-fold higher in endometriosis patients than in non-endometriosis. So that's quite something, and in the other way, reduction can also occur. So you can have that correlation, or you correlate it in tissue. So if you look at, for example, the eutopic endometrium, the endometrium itself, or you compare it with endometriosis tissue in the same patients, and you can see that some of the microRNAs are either upregulated or downregulated. So you can see there are differences between the normal tissue and endometriosis. Now, another big aspect is the omics, as you know, and there are different types of omics like genomics and transcriptomics and proteomics and metabolomics. And at least two major groups, the proteomics, have already been investigated to look into that. If you can use the different proteomes and how they are expressed and how they are produced, whether you can use it to diagnose endometriosis. And just the same as metabolomics can be used. So the metabolism of the cell can be investigated, and that's a bit similar like cancer, as I will show you later. Now, interestingly, since the features are so complex, it's not surprising that we need somehow kind of artificial intelligence to help us to understand how can we relate the many different features you can see. As I've shown you, just for microRNA, you've seen so many, and there are many more. So how can we use that in order to describe endometriosis? And in that publication, published this year, on artificial intelligence to understand endometriosis. And I'm not going to describe to you what's meant to be here, but it's just relating to endometriosis genes and the way the networking is done. So that's just to tell you that the proper diagnosis of such a complex disease requires more modern way of relating things together. So I think the important thing is to put the right questions. What do we need as a diagnostic? So to me, it would be important to have a non-invasive type. Then it should tell you the diagnostic feature, where is the disease, so the location. Is it active? Because that's often difficult to tell. And does this finding on laparoscopy, for example, or on diagnosis, relate to pain or fertility? Can we say whether this disease will progress or after treatment recur? And also whether the disease will respond. So it's a predictive diagnostic features. So if you are in oncology, that sounds to you a bit similar, because in my view, endometriosis is kind of a mirror to malignancy, because it has so many similar features that one could actually use many of the modalities which have been already well established in malignancy, to use it also for endometriosis. So if you go to cancer meetings, there have been many of these diagnostic features have been already or are in use. So if you look, for example, in breast cancer, breast cancer is not breast cancer in general. So you have different types. And here you can see how different types of breast cancer can occur. And according to this, you can actually treat the patients. So this is just an example how we could use this knowledge to have the different types of breast cancer types, let's say steroid hormone dependent ones, the ones who don't have receptors, and others who have got more growth hormone. So that's what you actually need to understand how the different endometriosis types are actually diagnosed, and also how treatment should be applied. Now, there's a major effort in the world now to use all the knowledge, but also the different diagnostic tissues which to be gathered in the same standardized fashion. And the World Endometriosis Society, together with the WRF effect, that's some of us are in these groups to collect the tissues and to enable us to find more descriptive diagnostic tools. And it's essential that you collect the tissues in a standardized fashion, otherwise, not just tissues, but others, otherwise it's difficult to interpret the results. So I hope I convince you that the playground for endometriosis is quite complex. So if you, this picture has been taken here in Canada, as you can imagine. And so it's a tough way of playing that game. So we all have to gather enough effort and information to be able to further our knowledge on diagnostics. Thanks very much.
Thank you very much, Ludwig. So we have some time for some questions. Anyone wants to kick off? Ludwig, the microRNA studies that you alluded to, how much of a variation across the normal menstrual cycle do you get of those potential biomarkers in normal women?
Yeah, there are variations, just like in the endometrium. There is quite a variation, and endometriosis itself is not that much, but it also probably depends on what type of endometriosis we're talking about. If there's more glandular, more stromal, more scar tissue, etc. So you mean throughout the different days of the cycle, right?
Yeah.
So there is some
obscure.
Of course, yeah. That's always a problem with cyclicity. Easy or difficult to do, or
what was the histology when you got it wrong? When the pathologist disagreed with you?
So
you had a couple that looked very much like endometriosis,
yes,
but the pathologist said not.
That's why I put up the slides, because I was surprised. Well, it's obviously different. It's depending first where you biopsy it. That's one thing. So that's even before the pathologist gets it. So I think there may be some mistakes in that, and some of the tissues have larger areas than just the endometriosis, so it depends where they cut it. So even if it's a very evident endometriosis, you may get it wrong by the methodology rather than the disagreement on the histology. And then there are many centers or many hospitals that don't really care much about endometriosis. So I put that in a very direct way now. But even in my department, it took me years to go through the evolution of determining what is endometriosis.
Dear Chairman and dear colleagues, well, I'll try to look at the era that's beyond 40 years. So I'll try to, go over some topics. I have nothing to disclose. Anyhow, endometriosis is prevalent mostly before the age of 40, but still we have, even in the postmenopausal period, quite high rates of endometriotic women who need assistance. And this doesn't change from population to population. This is a UK-based analysis, and still after the age of 40, like in 1,000 persons years, you have more than 1.3% prevalence. And it's the same from another study that's done in Israel, and still we have patients who are over the age of 40 and they have endometriosis. Well, the time to diagnosis differs between the age groups. It's not like in the early reproductive age. After the age of 40, from the symptoms that the patient goes to the physician, it's more than a year. And from the first visit to the physician to the diagnosis, it's another year. So it's a little bit faster, but still it will take like 2 years. And at this period of life, the symptoms might differ. Before the age of 40, you might have like cyclic menstrual pain. But after the age of 40, it's mostly the pain is non-menstrual pain, and still you have also dyspareunia. Well, having endometriosis also affects the time of menopause. Just it's the same like having infertility. And it doesn't differ whether you have oophorectomy, unilateral oophorectomy done or not. So still, it has an effect on the age when the patient will have menopause. So endometriosis is a risk factor. There are some guidelines, from different groups, but the way endometriosis care is should be given would first be the diagnosis of the disease. Well, we have modalities, as we had seen from my previous speaker. So it's like the pain has to be dealt with, whether it is gynecologically related or non-gynecologically related. And sonography in good hands might give the diagnosis and exclude any type of endometriomas could be excluded. And any nearby organs has to be still taken into consideration in terms of pain and any organ problems. Well, the treatments, we have the hormonal treatments and we have the painkillers. And surgery, yeah, if it is diagnosed during the surgery, the disease has to be treated. But in terms of deep infiltrating endometriosis, a good plan before the surgery has to be done. And maybe the patients should be referred to a center of expertise. We know that the hormonal and pain medications have been used by the patients. And like in 5 years' time, more than 50% of those patients are still on any type of medication. And we know that the procedures, if the lady has a surgery, the younger she has her first surgery, the likelihood that she will have recurrent procedures. And these procedures, they start from like 1 to 5, and those might involve different areas of the pelvis. Apart from that, we have two options. One is more conservative surgery, laparoscopically done. The other one is hysterectomy. And in any case, after the surgery, we have recurrences like after the hysterectomy, even though it's seen as 5% recurrence, if you go more conservatively, in a 5 years period, the patient might need another treatment, another operation in 30% of the cases. And regarding the medication after post-operative period, in 5 years' time, if she has even had hysterectomy, still there's a 65% chance of that person needing any type of medical therapy. Well, this is much higher in laparoscopy, which is around 85% in 5 years' time. Well, the age is also important here, because after the age of 40, it doesn't matter whether you follow the patient or you give her any hormonal treatment in order to diminish the recurrence rate for endometriomas. Well, endometriomas are diagnosed by ultrasound, but the way an endometrioma is detected might change through the years. So a 25-year-old woman might not have the same appearance of an endometrioma as a 45-year-old woman. So the character of the sonography might change. The tenderness of the mass, it tends to decrease after the age of 40, whereas the papillary structures tends to increase. Well, we know the pathognomonic ground glass appearance. After the age of 40, the probability, even though it diminishes, it is more homogeneous that you might see. So it's not, every time that appearance might not be pathognomonic. Also, the papillary flow after the age of 40 kinds of increases. Well, in terms of the color score of the scan, this is all about ultrasonography, by the way, we have all sorts of probabilities. So the problem during the perimenopausal and even for the postmenopausal area is really to distinguish whether this adnexal mass is benign or malignant. And the IOTA group, they came out with some simple rules. And on the left side, you see the 5 benign characteristic appearances, and on the right, we have the malignant appearances. And bear with me, the right upper sonogram is suggestive of a benign cystic teratoma, whereas the left upper one is of endometrioma. So we have these simple rules, and from these simple rules, with an algorithm, there is a way of evaluating the risk of the patient to have an ovarian malignancy. So this could be used for differential diagnosis in cases of endometriomas that might be mistaken for any malignancy. And even this group also has on their website another model, ADNEX, which is called ADNEX model, where you can fill in the blanks and then a risk score would be calculated. And this might help you to decide whether to follow the patient or just send them to a gynecologic oncology team. Well, different MRI evaluations were also being done, and apparent diffusion coefficient, well, I don't know this, but it is something related with the radiology fellows, has been shown that this would be another way to decide whether the condition is benign or malignant. In terms of deep infiltrating endometriosis, we have 2 options, medical treatment and surgery. And pain is the symptom that brings the patient to the physician. So if the pain medication works, then that's okay. But if not, in some cases, surgery is inevitable. And we have 3 types of surgery, and the bowel stenosis or the length of bowel infiltration might be the things that you decide what type of surgery that patient really needs. Well, some patients might not go for surgery because surgery has some complications you can see on the right side. And even with years follow-up, you can see on the left table that no pain relief is 100%. So still, some patients might not be quite happy with the surgical procedure. And in one paper, NETA, 2.5 milligrams per day, has been given to a woman who had deep infiltrating endometriosis. And the comment was that it was quite effective as a diagnostic that has been talked about previously. Well, coming to postmenopausal period, of course, it has to be either combined estrogen progesterone or maybe tibolone. But in this era, there is another thing that these ladies might have endometriosis-related cancers, or even the overall cancer rate in some other organ system might increase. So if we can come up with an algorithm, especially for the postmenopausal period, first of all, if the patient has pain, we have to relieve it. And secondly, for any type of endometriomas or adnexal mass, we need to exclude malignancy or atypia. And at this era, at this period of the woman's life, still there is the recurrence of endometriosis, so women need to be consulted. Well, pain is a little bit different at this stage. This study shows that in women at the age of 46, their pain intensity is increased if they had endometriosis than the control groups. And this was mostly during work time. Different medications has been used for pain relief during postmenopausal period. Here you can see some aromatase inhibitors in different dosages and in different periods. So that could be an option. And postmenopausal deep infiltrating endometriosis has been reported in the literature, and they use the conjugated estrogen bazodoxifene quite successfully. So this could be an option. In terms of endometriosis and cancer, this study compared once a woman who had endometriosis with the general population, and it turned out to be that the woman with endometriosis seemed to have higher likelihood of either breast cancer and ovarian cancer. Well, there are some differences. First of all, the time since the diagnosis has been done differs. Like here, as you can see on the table, if it's between 5 and 9, then the likelihood of ovarian cancer seems to be high. Whereas if the diagnosis has been more than 10 years, it's endometrioid cancer. Well, if the diagnosis was in her third decade, then the lady would have an increased risk for ovarian and endometrium cancer, whereas if the diagnosis was after the age of 50, it would be ovarian or breast. Well, this was done after analyzing more than 45,000 women. And still, the histology would differ. In terms of ovarian cancer, it would be mostly endometrioid or clear cell type. And still, on the lower table, you can see that the time of the diagnosis is important. If it is past more than 5 years, it's mostly clear cell carcinoma of the ovaries. And still, the age of the diagnosis is important. Before the age of 50, if the diagnosis was done before the age of 50, it's mostly clear cell carcinoma, whereas after the age of 50, it would be serous type. Well, we said women have endometriosis, and they are in their postmenopausal period, so they would need probably some type of hormonal therapy. Well, what about the recurrences? There have been case reports given in the literature, and the recurrences were seen in different areas like bladder, ureter, intestinal area, rectal ward. And when these case reports were analyzed, even though most of those people were on only estrogen hormonal therapy, some used combined hormonal therapy. Well, surgery, after with surgery, still there might be some endometriotic foci left behind. And in the literature, you can find some cases where malignancy has developed in those endometriotic foci, and different types like clear cell carcinoma. These are not ovarian cancers that I had mentioned before. These are the cancers where the endometriotic sites were other than the ovary. So different types of cancers have been reported in the literature. Well, what about the quality of these trials that assess the risk of endometriosis recurrence after HRT? One thing is for sure that it's better to start immediate hormonal therapy rather than waiting for a long time. And again, HRT, estrogen, progesterone, given together seems to be a good option. And if we want to prevent recurrent operations, it's better to clear as much of the disease as possible. And if you don't want any pain recurrence, then maybe taking out the ovaries might be a choice. And tibolone also is another option. Well, we know that the lifetime ovarian cancer risk is 1.3%. And in women, this is 2 to 3% who have endometriosis. Well, with hysterectomy and oophorectomy, and even with tubal ligation, the likelihood of ovarian cancer diminishes. So in terms of following women, ultrasound and even MRI could be used. With the ultrasound, two things that one is hyperdense mural nodules you can see on the right upper and the right bottom sonography, the mural nodules, or during your follow-up, if the endometrioma increases in size, then that could be a sign for malignant transformation. And that cases could be confirmed by MRI, because these just you can see the MRI image over there. The mural mural nodule could be easily seen, and then these patients could be sent to a gynecologic oncology. Well, hormonal therapy is important in order to prevent recurrence, and during the follow-up, ultrasound could be easily used. And complete surgical resection, if the patient undergoes endometriosis surgery, of course is something that has to be consulted with the patient. And the possibility of oophorectomy and salpingectomy needs to be, again, offered, and those decisions has to be individualized. So in terms of clinical approach to a woman who had endometriosis and now are in their postmenopausal period, they should know that endometriosis might recur. And even women who didn't have endometriosis before could get the diagnosis after the age of 50. And there is this possibility of malignant transformation. And those patients, if they need any type of hormonal therapy, it should be either combined, estrogen, progesterone, or maybe tibolone. And other, like SERMs, combined with estrogen or aromatase inhibitors, could be also considered as alternative treatment. And of course, there are some emerging treatments for endometriosis, and hopefully we'll find the right combination for the right person. Thank you for your attention.